Welcome all. Today, we're talking about one of the grossest specimens to come across the gross bench, teratomas. This is not one for the faint of heart.
Hey everyone, I'm going to present this next specimen, which is in keeping with what we've been talking about, but slightly different. Before I show the specimen, I just wanted to ask a question in the chat. This particular case that I'm going to show was resected from a year-old woman for a right ovarian mass. So maybe just in the chat, generate some ideas of what this might be. Again, this is a resected specimen for a right ovarian mass.
Yeah, it could be serous as well, but typically not. And it is indeed serious also. Yeah, borderline, yes, topic pregnancy. Thank you. Okay, I think those are a good differential list for adnexal masses in young reproductive age women.
So with that, I will show you what the specimen is. Any ideas what this is?
People have had breakfast.
Awesome. This is indeed a teratoma, and I'm going to put away this really lovely looking piece. Okay, great. So going to the actual ovarian mass, this was received intact, and just from a technical handling standpoint, the important part is when we're receiving this and you've got this history where you don't really know what it is, and when you've received it, it feels a little bit solid, it could be cystic. One of the important parts is to paint the ovary with silver nitrate, as we have done in this case, before cutting it. We also want to measure it because once you cut it, you're going to lose how big the specimen was. So in this case, we painted it with silver nitrate, measured it, and it's about 14 by 12 by 8 centimeters. So you can see how when we cut it, you lose some of that size. So it's helpful for the person coming along who's going to be grossing it to know how big it was when it was received and to make note of whether it was intact or not. Okay, so from there, obviously, some of the cyst contents you'll notice was that yellow, fatty, it's a sebaceous, disgusting material. This is probably most people's least favorite specimen to gross. At least a number of the PAs here have expressed that position. So
hold on. So do you think if you poll PAs across, this would be one of the grossest, most disgusting specimen and disliked specimen?
I think, yeah.
Unanimous, wow.
Unanimously hear that everybody hates grossing these because they're just gross. They're not so bad when they're 4 or 5 centimeter specimens, but when you get the ones that come in the bucket that have a couple of liters of that yellow stuff.
The sebum.
Yeah, so it's very often filled with hair and it's gross. So going back to our specimen, so once you open it, you want to talk about the cyst contents like you would in any other specimen. And looking at this, you've got lots of this sebaceous sebum, but you also start moving across into some more solid areas. And so here, a lot of these projections will often have a skin-like appearance, will often have some hair sticking out of it. Can anybody tell me what this nodule or what this protuberance inside the cyst here is called? Yeah, this is a Rokitansky nodule or Rokitansky protuberance. And very often it has a skin-like appearance. You can see another one here where you've got almost this layer of skin, and underneath it you have some fat. Very commonly you'll find calcified areas in these nodules. And in this one, as it falls apart.
That is so gross.
In this one, I've got, I don't know if we can see it there. There's a little focus of black pigmentation, and it's gray in the middle. So why are these nodules important? Does anybody know the significance?
It's usually a collection of mature components rather than immature. So that's a reassuring feature. Usually you won't have immature quite obvious like this. And if you have an immature component, they tend to be way more solid rather than protruding into the lumen. We'll do our poll. The teratomas are probably one of the oldest characterized ovarian pathologies. Which of the following has not been attributed to teratomas? So most people chose hemolytic anemia. In fact, that's one of the more common associations. But again, this is relative. These are all very rare complications of teratomas, but hemolytic anemia has been associated with teratomas. Limbic encephalitis. That's also been associated through a perineoplastic type of phenomenon, depending on what type, the most consistent type of cell in the teratoma might be. And that gives you a whole bunch of neurologic complications due to the inflammation in those brain areas. Peritoneal deposits can happen, specifically in one type of a monodermal teratoma. Does anyone know what that is? Yep, that's right. Gliomatosis peritonei. Thank you. And abdominal pain secondary to torsion. These things can tort. As you can imagine, they can be quite large. So yeah, abdominal pain is probably the most common. But fever of unknown origin has not been demonstrated to be associated with teratomas. Okay, so hold on. I think I've got another question regarding this. Let me just put it up. What are the 3 different types of teratomas? Let's put it up in the chat. Yep, mature, immature, and monodermal. Thank you. So this specimen here is considered mature. And what's the definition of calling it mature? All 3. There you go. At least 2, but most common, all 3. So you need representations from the ectoderm layer, mesoderm, and endoderm. Immature, which is not the topic here, but we can go into that if you wish, needs more immature neuroepithelial, neuroectodermal type of components, and grading is based on how much and how often you see these things. A monodermal is, as the name implies, one predominant cell type. So the most common being struma ovari, where it's all just thyroid tissue, and there's also the carcinoid monodermal teratomas. Okay, did you want to just go about how we're going to gross this?
From a grossing standpoint, we would measure the specimen in 3 dimensions, talk about the contents of the cyst. Most often, these are very thin-walled cysts, as you can appreciate here. They're not very thick, but when you do get to the thicker areas, you do want to be aware of these Rokitansky nodules and protuberances, describe them as such, and then sample them. You're still looking for some of the papillary excrescences that you would see in any of the other cystic lesions of the ovary. And if they're there, you would describe and submit. But when it comes to the Rokitansky nodules, once you cut through them, you're going to find there's these calcified foci in them. They may just be calcified foci, or they might look like teeth, more rudimentary teeth-like structures. When sampling the Rokitansky nodule, you'll want to submit them in their entirety and just getting around and cutting through and dissecting around some of those calcified components. If you have the fallopian tube attached, you'll also submit that as well. In terms of the number of sections, generally speaking, again, 1 per centimeter, and again, finding all those Rokitansky nodules and submitting them through in total.
You calcify them?
No, we wouldn't generally submit the calcified components because we know that they're within the normal range of what these cysts do, but we wouldn't submit them for decalcification.
Okay.
And I've changed my gloves 3 times if anybody cares.
Where's the hair?
The hair is inside that big ball of sebum.
I thought I saw hair. All right, one more poll. Oh, there was a request to show it, but Brian is putting his foot down. Okay, about 1% of these dermoid cysts undergo malignant transformation. What is the most common?
And it's for this reason that we want to put through these Rokitansky nodules through.
So yeah, most people got the right answer in that squamous cell carcinoma is the most common malignant transformation. Mostly because, as you probably know, the most common component of dermoid cysts is skin. So that just makes sense. The rest are quite uncommon. Thyroid is common if you're looking at the monodermal teratomas, in which case like a struma ovari. PTC would be a common transformation for that one. And then one last question before we end off. Which of the following ovarian surface epithelial tumors is associated with a mature cystic teratoma? Yeah, most people got the right answer. Mucinous is commonly associated with mucinous surface epithelial tumors. There's some interesting literature suggesting that potentially this is actually an origin of mucinous epithelial tumors. Oh, there's a question, hold on. Does monodermal teratoma look differently grossly than this specimen? Yeah, they tend to be more solid. Depending on the degree of differentiation, they can be quite solid. Ideally, yeah, you won't have all the mess too. That's right, struma can look a lot like thyroid, that beefy red look. Yeah, I forgot about that, yes. It can be quite striking. So got an ovarian theme going today, and we ended up with something gross and disgusting. Thank you all.
Thanks,
Have a
everyone.